So if I could have your attention, please. So I'm Lajos Pusztai. I co-direct the Cancer Center Genetics and Genomics program, and it's my pleasure today to introduce two of our members, the members of our program, to give grand rounds. So Dr. Antonio Omuro is going to be the first speaker, and is going to talk about challenges and opportunities in brain tumors. He obtained his MD degree from the University of Sao Paulo in Brazil, fellowship at Memorial Sloan Kettering, and then a clinical research fellowship at Sorbonne University in Paris. Subsequently, he joined the faculty of the University of Miami as the director of the Yale of the Brain Tumor Center there, and also the chief of the Neuro-Oncology Division, and joined Yale, I think, last year to be the chief of Neuro-Oncology here, and also to direct our Yale Brain Tumor Center. So, Dr. Omuro.
Well, thank you very much for the opportunity. So today we're going to talk a little bit about what we're doing within the brain tumor program and what kind of plans we have to develop this field within Yale. So again, today we're concentrating on primary brain tumors, and brain metastasis is another portion of our program that I will leave to Dr. Veronica Cheng to talk about some other time. So when we're talking about primary brain tumors, we're talking about gliomas, anaplastic meningiomas, CNS lymphomas, just to name some of the most common tumors. And these tumors are not so frequent, thanks God, right? Because otherwise it would be really a health crisis. We have about 24,000 patients with that diagnosed every year in the United States with these diseases, and even though they're not so common, they account for the number 10 cause of death in this country, and that is because the prognosis is so poor. So this accounts for about 18,000 deaths every year in this country. And of course, because of the anatomical location, these tumors cause a lot of problems in terms of quality of life. And I'm pretty sure that if you were to pick one cancer not to have in your lifetime, I think pretty much everybody here would pick glioblastoma, because not only these are very malignant tumors, but they also cause a lot of neurologic symptoms, and every little growth could come with a big price in terms of intellectual and neurologic function. So the glioblastoma is the most common primary brain tumor. And in clinical trials, the median overall survival from diagnosis remains about 18 months. And outside clinical trials in this country, the median overall survival is only 11 months. So basically a death sentence and also a downward spiral in terms of quality of life from the time of diagnosis to the time of death. The standard treatment remains surgical resection whenever possible, followed by radiation with concomitant temozolomide and adjuvant temozolomide. And as you can imagine, these treatments have been around for a long time, and with minor variations, we are doing the same thing that we were doing for the past 30 years. So this is a very dire situation for these tumors, and this was not for lack of trying. So you're looking at a slide from a review that we wrote in 2005. And at the time, we were very excited about all of these targets, all of these pathways. The preclinical data was looking great, and clinicaltrials.gov had tons of clinical trials in recurrent glioblastomas. But one after the other over the next few years actually failed to improve survival. And more worrisome is that not only these trials failed to meet that primary endpoint, they also failed to give us very basic answers on why these things that were looking so promising in preclinical data actually did not pan out in clinic. So is that because we were basically addressing the wrong targets? Maybe they're not particularly relevant for oncogenesis, or there's too many feedback loops or redundant pathways. Also, we're learning more and more about how these tumors evolve over time and how they are heterogeneous in terms of spatial distribution from a molecular standpoint. But in the brain, there is the additional problem of the blood-brain barrier and how we can find drugs that can be potent enough to act on these targets at very low concentration. So they have to be either very potent or they have to cross through the blood-brain barrier. Also, these trials were not particularly good at selecting patients based on the targets that was being tested. So a lot of them had no selection at all. And those who did have selection actually based their selection on archived tissue from the time of diagnosis. And again, these were trials in recurrent disease, and maybe those targets were no longer relevant. And up to now, we're still debating on how to select these patients for the trials. Should we have more homogeneous groups, maybe base these trials on transcriptional subgroups, or maybe we shouldn't continue not to do any selection in the hope to find super responders and then dissect that mechanism of response in that individual patient. Bottom line here is that we need more science linked to the clinical trials, and we need also to expedite whatever is happening in the lab towards more meaningful treatments for our patients. So what are the current trends out there in terms of clinical trials in brain tumors? So the first question is, what's happening to gene sequencing? And as a reminder, glioblastoma was the very first tumor that was sequenced by the TCGA effort. And is there any application for all of that knowledge that was generated? And there was a lot of excitement at the time. Well, it turns out that there is a lot of applications for the genomics, but at this point in time, one of the main uses is actually in terms of diagnosis. So here we're looking at these are all glioma patients, and as you can appreciate from a genomic standpoint, they are very heterogeneous groups. But when you look at the genomic signatures of each of the glioma subtypes, you can actually see how the molecular information really classify these patients very nicely and resolves all of our issues that we have with pathology. So here, this first group here, you're looking at the very typical signature of oligodendrogliomas. So remember, these are the tumors that have 1p19q co-deletion, ID8 mutation, third promoter mutation, CIC, and FUPP1 mutations. So this is very typical, and that this is, again, oligodendrogliomas are typically grades 2 and 3 tumors. And the other grade 2 and 3 tumor is the astrocytoma that has this also very typical signature with IDH mutation, ATRX mutation or loss, and TP53 mutation. So back in the day, we had these so-called mixed gliomas. That was something in between those two tumors, but it turns out that the genomics actually resolved that. With the genomics, you classify most or the vast majority of these tumors in either one type or the other type of grade 2 and 3 glioma. So nowadays, this so-called mixed glioma is actually being abandoned, and we are now talking about the molecular signatures, and this has been incorporated into the whole classification. Now, looking at these folks here, you have no difficulty in recognizing the glioblastomas, right? So this is the grade 4 tumor. You start to see the EGFR amplification or mutation. You start to see CDK mutations. You start to see P10 mutation or loss. Again, a signature of grade 4 tumors that we don't see in grades 2 and 3 tumors. So again, this is very easy to recognize. So nowadays, sometimes you get a tumor that has this type of molecular signature, but with a more benign histology. Actually, you go with the molecular signature because these patients are doomed in terms of clinical behavior based on their glioblastoma signature. And here you're seeing, for example, some gliomas that the pathologist could not classify. But if you look at their signatures, you can actually tell if they are a glioblastoma, like these folks here, or if they are an oligodendroglioma or an astrocytoma. So again, the genomics is extremely helpful in terms of providing information for the diagnosis. Another interesting thing that we found here was that the number of mutations is actually small in gliomas. So the mutational burden is low, except when these tumors recur. And when they recur, you start to see some of these very highly hypermutator tumors, and these are the so-called hypermutators. And we're going to talk a little bit more about those in a second. But overall, even in the recurrent disease setting, the mutational burden tends to be low aside from these exceptions. So again, very helpful for diagnosis, but what about in terms of actionability of those mutations? And again, what you're looking at is our results from my patients at Memorial. And when we looked at how actionable these mutations are, we don't have much actually going on in gliomas. So the most, like the closest one for actionability is actually BRAF V600E, and that is found in epithelioid glioblastomas and pleomorphic xanthosarcocytomas, but again, very rare, about 1 to 2% of all gliomas. For everything else, that remains very experimental. IDH mutations are very common, but at this point in time, we don't have a specific treatment based on that signature. And we have all of these other potential targets, hotspot mutations, and other potential pathways that we can target, but that remains in the clinical trial arena. But to make our lives a little more complicated is that this, in fact, is not very stable over time. Like these mutations are not necessarily found at recurrence. And this has come from several other studies. Here we're looking at a study here from Yale, from the Gunnell's lab. And just to give you an idea on how this evolves over time. So this is one of my patients that had an IDH1 mutation, or TRX TP53, so the typical astrocytoma signature. And at diagnosis, the patient had PDGFR amplification that comes with KIT. The patient had CDK4, AKT1, PIK3CA. So these could potentially be something that we could use for matching the patient to a clinical trial. But this patient did reasonably well, and then when she recurred 4 years later with a little thing here in the frontal lobe, we ask ourselves, okay, so what should we do with this patient? Should we go with one of the trials based on these abnormalities? So the thing that I did here was to ask our surgeons to actually remove this, and this was relatively easy because it was a frontal lobe right side, so very easy surgery. So this patient was re-resected, and to our surprise, all of those targets were actually gone, replaced by passenger mutations. So what's driving this tumor now is very different from what was driving back in the day. So you can imagine that typically we would not operate on this patient. We would put her on a trial of one of these targets. And of course, there was no chance for those drugs to act because those targets were no longer present and driving this tumor. This is another example of a glioblastoma patient, again, with a glioblastoma signature with some potential targetable mutations here. But then when the patient recurred, we can see that new targets appeared. Now that we have even PDGFR amplification that was not present before. And even the TP53 mutation was different from the diagnosis. Again, speaking of how these tumors change over time and how we need updated molecular information to actually try to match these patients with the clinical trials. And then we start to see these that I mentioned before, which are the so-called hypermutator gliomas. So these are tumors that we create by giving them temozolomide. So temozolomide can cause mutations in mismatch repair genes. In this case, most often it is on MSH6. And these tumors then develop these enormous amounts of mutations, become very rich in terms of new antigens. So this is kind of information that we need to know at recurrence, because if you don't bring the patient back to the OR, you won't know that they are hypermutators and they need different treatments as compared to the time of diagnosis where they had very simple molecular signatures. Now, trying to smell and figure out who these hypermutators could be. So they can come from all types of gliomas. They can be, they could be from a de novo glioblastoma that recurred, or they could come from IDH1 mutants. It doesn't matter, the MGMT methylation status. What we do find interesting is that these typically are long-term survivors. So the median time from initial diagnosis to the diagnosis of hypermutator was 64 months. So they were, to begin with, kind of outliers in terms of survival. They also received a lot of temozolomide. So the cumulative dose of temozolomide was about 17 grams per meter square. And but after they have a diagnosis of hypermutator, they are not doing so well. The median progression-free survival was only 3 months, and the median overall survival was only 16 months after the diagnosis of hypermutator. So this is information that we do need to know. In our sample of recurrent tumors, this accounted for 26% of patients. So one of the most actionable mutations that we can actually find in these tumors. So this is information that is very important for us to act on and bring these patients back to the OR so we can make this diagnosis. So here are the current trends for trials in this disease. So a lot of the trials are focusing on newly diagnosed disease because you have fresh tissue and you have fresh molecular information, and that's also an easy patient to deal with. Also because the mutations are so rare in itself, so it's 1% of a relatively rare disease, so it's hard to have a clinical trial dedicated to that specific mutation, so we tend to rely on basket trials. The problem here is basket trials oftentimes exclude patients with brain tumors, so we have to fight with the companies, fight with whoever's designed the trial to actually squeeze these patients in, because otherwise they're left out. The other trend is that we are resampling, as I mentioned to you, these patients more and more, so it's very important to bring these patients back to the OR, exclude a hypermutator phenotype, and that is a little bit problematic because you can imagine that not all patients, number one, can be safely operated on, and the benefit of the operation outside a clinical trial is also somewhat debatable. But that's the current trend, so whenever we can, we do that. Another trend is to try to, of course, design trials that are targeting these so-called truncal mutations, so earlier mutations. And, of course, try to develop trials targeting more stable targets. So talking about stable targets, the next question is, so what's happening to immunotherapy in these tumors? So we do know that glioblastomas grow in an immunosuppressive tumor microenvironment. So they produce lots of proteins that are, immune checkpoints and other mechanisms that actually render them very invisible to the immune system. But again, for brain tumors, it's also more complicated than other tumor types. So first of all, the brain has been traditionally seen as a sanctuary site in terms of immune responses. So that starts not so well for us. Then we have these tumors that are growing very fast, and we have to have an immune response that is even faster. So the immune response cannot be outpaced by the growth of these tumors. Also, this battle between cancer cells and immune system is happening in the brain, and that can be good, right? So there is a risk of neurotoxicity there. And also, to complicate our lives is the fact that we use MRIs to follow these patients, and the MRI cannot differentiate between tumor growth and inflammatory reaction, because if you see something growing, not necessarily that corresponds to tumor that is out of control. It could be actually immune infiltrates and inflammation, making the tumor look worse, which is what we call pseudoprogression. So this is, again, makes our life much harder than the general oncologist. And we did try immune checkpoint inhibitors. Here is the first study, and Yale participated. Dr. Bering, who is here, was an active participant in the study. So we treated 40 patients with nivolumab, or 2 combinations of nivolumab and ipilimumab in this trial. We did look at the target expression. So there was 68% that had PD-L1 expression. So that didn't seem to be a problem of target. But then we didn't see any brain toxicity. So I started to get a little nervous that nothing is happening. And the overall survival was 9 to 10 months, very similar to historical controls. We did see some responses. Here you're looking at one of these patients that had a lot of immune infiltrates, but the majority of the patients that were brought back to the surgery after they received these drugs, we didn't see any immune cells anywhere to be found. So now this BMS did not want to understand this better. They went directly with a phase 3 trial, which sure enough was negative. So we didn't understand who were the responders, if there were responders. Now there's some subgroup analysis, maybe the patients that have MDMT methylation tend to respond a little bit better, especially if they're not on steroids. But there's also some investigation on whether we should use this before the surgery, because then you can expose the patients to a lot of new antigens and then remove some of the tumor to give more time for the patient. And also the surgery could improve the immune response. But in any case, for unselected patients, this failed completely. Of course, the question that remains is whether this is all because of the low mutational burden that gliomas are associated with. And that is a question that remains to be answered. But again, it's also possible that PD-1 is not the right immune checkpoint in these tumors, and it remains to be answered whether the issue is actually, the problem is the brain location and whether an immunotherapy will ever work in this so-called sanctuary site. So to investigate one of these questions, this is one of the trials that I launched, which is basically using pembrolizumab for those hypermutators. Remember those that I showed you that have these very high mutational burden with lots of new antigens. So at least for these patients, we're collecting tumor and blood to try to understand if, okay, so in this case, the problem is really not a low mutational burden. These have very high mutational burden. So we want to understand if in this case, we are triggering any kind of meaningful immune response. Now, what about Yale and what are we going to do here to move this forward? So the main two initiatives in our group are an application for a spore. So this will be a brain tumor spore led by Dr. Gunnell and myself. And we are creating a brain tumor center, which is co-led with Dr. Moliterno, Dr. Sheng, and Dr. Bindra. So just briefly, what we have for the spore at this point in time. So one of the projects is to try different immune checkpoints that may be more relevant to the brain. So for that, we actually partnered with somebody who actually understands the immune system in the brain. That is Dr. Hafler's lab. As you know, he works in multiple sclerosis. So he knows that the lymphocytes can go there and how they go there and why they go there. And what his hypothesis is that one of the main, the most important immune checkpoints in the brain is actually a target called TIGIT. So he looked at TIGIT expression in patients with MS, and TIGIT is not protecting the brains of these people. And when you look at the TIGIT expression in glioblastoma, that's much more higher, it's much higher than PD-1 expression. So the idea came of targeting TIGIT to see if we have a more meaningful response to the immunotherapy. So in partnership with Arcus Bioscience, we're launching this Yale-led multi-center trial where what we're going to do is we're going to enroll patients who are candidates for a surgical resection at recurrence. And before the surgery, we're going to randomize them to receive anti-TIGIT, anti-PD-1, the combination of both, or placebo. And then 2 to 3 weeks later, we're going to bring these patients to the OR and then resect the sample, get the samples, both tumor and blood. And then we're going to do a single-cell RNA sequencing to try to understand if TIGIT is better than anti-PD-1, if there is a role for the combination, if the combination is better than each of these agents alone. And again, bring all of this information back to the lab to see if there is a path forward. And that is way before we actually think about a randomized trial with a large number of patients. So again, a very boutique type of trial to try to understand the biology before you go with randomized trials where you put a lot of patients in that are very costly. Another project is something that has been already talked here a few times. So Dr. Bindra, who is here, is studying IDH1 and 2 mutants to try to understand what the byproduct of this mutation, which is 2-hydroxyglutarate, what that does to DNA repair. And his discoveries are around the fact that 2-HG create this BRCA in these tumors that could potentially be targeted by PARP inhibitors. So he has partnered with Dr. LaRusso and also University of Virginia and launched 2 trials based on this concept. And the project for the spore will be for biomarkers around those 2 trials. And then another project has to do with recurrent meningiomas. So as you know, meningiomas are very benign tumors, and it is very intriguing that when they come back and then they do not respond to radiation, they are very malignant tumors. And Dr. Gunnell's lab has the largest collection of annotated meningiomas with genomic and epigenomic information. And what came out of his studies was that not much was happening in this malignant transformation in terms of genomics, but this all seemed to be driven by epigenetic changes in these tumors. So these tumors are basically driven by NF2, and when they recur, they look exactly the same from a genomic standpoint. So the idea came that maybe we should use epigenetic targeting drugs, and in this case, we're going to use a bromodomain inhibitor, and the model of the trial is again the same. So we're going to give drug, bring the patients to the OR, and try to understand at a transcriptomic level what the drugs are actually doing to these tumors. And as you know, the spore projects are selected based on what's ready for clinic. Then the spore has also these developmental projects, which means that things that are getting closer to clinic. And one of the exciting things that are happening at Yale is the use of nanotechnology. And these are partnerships with the Neurosurgery department and the Biomedical Engineering department. And we have these 2 investigators, Jianbing Zhu and Mark Saltzman, who are doing a lot of work on this. And they are trying to apply nanoparticles, number 1, to try to maybe overcome the blood-brain barrier, so improve the drug delivery to the tumors. Also, another potential use is to actually directly inject the nanoparticles into the brain, and through convection enhancement, they actually diffuse around the tumor to see, again, if we can improve the delivery of the drug to the tumor cells. And the holy grail of this technology is one day perhaps try to deliver CRISPR-Cas9 with the idea of treating these brain cancers with gene therapy. But again, this is at infancy, but it's very exciting projects that are coming out of Yale Science. And I could spend the whole day here talking about all of the science that is happening in brain tumors. So these are all scientists that have new patents, new mechanisms of actions, and new hypotheses that are, you know, I don't even know how to select projects for our spore because they have so many exciting findings. And the question is how we're going to integrate all of the knowledge of all of these laboratories into something more cohesive and like a teamwork. So for that, we are actually creating a brain tumor center. So the brain tumor center has this mission of gathering all of these people together, having them exchange ideas. So science will be a very important component of this, but we want science that actually reaches clinic. And we want a lot of emphasis on translational research. And the tumor center will also be responsible for improving the clinical care that we're delivering for these patients. So we will have a clinical care effort and of course some development and marketing to send our message out, improve the numbers of patients enrolled in clinical trials, and see if we can become a destination center, at least for brain tumors. So one of the things that the brain tumor is, we're planning to do it differently from other brain tumor centers out there, is to start integrating AI and deep learning technology early on in all of our projects. So as you know, data science is a high priority for Yale. There is a lot of resources available here. In fact, the hospital has a Hadoop cluster with data lake. So this is the type of computer that Google and Facebook use. So they are very powerful computers that can be expanded. And we have not 1, but 2 supercomputers, the NVIDIA DGX-1. So all of this resource is something that we want to use and put in contact with all of our investigators and our clinicians. So our investigators, of course, using this already for genomics and for drug discovery. But we want to use this for clinical research and more basic clinical work as well. So one of the things that we're doing is in partnership with Sanjay Aneja, who is from a radiation oncologist with a background in mathematics, we're putting together a few pilot projects to bring AI and deep learning into clinic in a faster way. As you know, as an industry, we're very behind as compared to other industries out there. As by that, I mean healthcare is very behind. So we're going to change that and have Yale led this transformation with integrating all of this knowledge into clinical work. So we have these three projects. One of the projects is on CNS lymphomas. So we're using one of Dr. Bering's data set of lymphomas, and we're going to teach the machine based on one MRI scan who's going to survive, who's not going to survive, basically who's going to be cured, who's not going to be cured. And then the machine developed these algorithms, and then we're going to validate that with one of my national clinical trials from where I collected all of the data in terms of imaging, and then we're going to see if the algorithm pans out. We also have a cool project using virtual assistants to capture patient-reported outcomes. So this is basically giving echoes to the patients, and then the patients will talk to Alexa, and then we're going to analyze the tone of voice and many other parameters that the machine actually captures if the patients are having issues with quality of life, side effects, and even depression. So with that way, we want to replace all of these very cumbersome questionnaires about quality of life and depression. And another project is to look at Connecticut's distribution of brain tumors and see and analyze our referral patterns to see where these patients are coming from, to see if we can then deploy our resources based on these geographic deserts that we will identify through the analysis of the referral patterns. So these are all very exciting projects that are ongoing. And I think we are at a crossroad here. We're hoping that we will make a big difference as soon as we put all of this Yale science to work for us. We clearly need disruptive technology because, again, 30 years with no improvement is really something that maybe we hit a wall and we need something completely new to change the game. Clearly, Yale research has provided an unparalleled intellectual capital. I've never seen so many brain tumor sciences in one institution. And what we want to do is have the Brain Tumor Center to match this problem with the solvers. And if you think that this is not possible in brain tumors, I just wanted to remind you that we did this before in CNS lymphomas. So this was my very first trial that I developed at the Vail workshop, where we used kind of a disruptive technology of the time, which was a very toxic high-dose chemo that we actually achieved a cure in 81% of the patients. So we have a long road ahead of us, but I think it is a fun and nice road, a little bumpy and curvy, but we think we have the right people on the bus. We have a lot of support from Dr. Charlie Fuchs, and just wanted to remind you that we have a retreat for the center upcoming this Thursday. If you want to participate, just shoot me an email and then I can send you the invitation, and there will be lots of good food, great science, and free cocktails. Thank you very much for your attention.
So thank you, Dr. Omuro. So because the two talks are rather different, we will have 5 minutes to ask questions. And I will also ask Dr. Neugebauer to load her slides in the meantime. So we will have time for maybe 3 or 4 questions.